Welcome back. You're watching the Front Row with me, Abi Agina, and today's focus is on maternal health care in the country. Are our mothers at risk? That is a very important subject of discussion here on the program. Well, before we get back to our guests, we'd like to also remind you, you can share with us your thoughts on our Twitter handle at KTN News KE, and you can also take part with our Slido platform, which the event code is the Front Row. We want to open up and just get to see what are some of the questions our viewers are asking out there. Well, a couple of questions already coming in, and we should be able to beam them shortly. Well, the first question is from Thomas Kipkemboi Kapkeno. Is in Tinderet, Nandi County. Thank you for the program. We appreciate you are watching us. Now, my question is, can there be an initiative to train nurses in marginalized areas and build them working apartments so as to aid the needy mothers too? They really feel the pinch down there in rural areas. Thank you. We have another question here from Wanaoni Michael. Humanity left human beings. We celebrate taking photos and videos instead of helping people in need. The Pumwani incident is an eye-opener to our loopholes in bad governance. Poor road network in rural areas has also made mothers to birth on the roadside. Names like Wangila and Mwanzia proves it. Thank you so much for your questions, and we'll be putting them out to our panelists who can chip in on behalf of each other as we progress with this very important discussion. And let me just quickly take the first question to Dr. Oluga, and like to just get your reaction to that question around building nurses' apartments. What do you have to say to this?
Yes, I think that that's something that is very appropriate, and it should be explored by all government agencies as part of the housing projects. I think it's important to provide for healthcare workers housing where it's accessible to the facility. As a matter of fact, actually, one of the code of regulations for many healthcare workers is that they should ideally be living within 15 minutes radius. 15 minutes radius to the facility where they work, because they can be mobilized anytime, not just when they are on duty, but also sometimes when they are off duty, when the facility is overstretched, when there are accidents. And these are things that I know many of our facilities have not achieved. Here, like in Pumwani, I think we have a nursing, we have some staff quarters, but of course it cannot accommodate everyone. So we usually have at least some a minimum number of people who are housed within a facility and who can always be mobilized for emergency. But I believe that this is something that we can support, and progressively as a country look at how to implement. On the other question about training of nurses, I think this is something that also is very important. But beyond training, I think, and I want to speak to my colleagues who are healthcare workers, and I hope they get this message very clearly. I think that we have fought long and hard to be recognized and to have good working conditions. And I've been part of that journey and part and parcel of the people who've championed, and we still do, to try and make sure that we improve the morale of every single healthcare worker. And we are very well trained in the universities, but I think also we should not use some of the issues of morale to sort of, abandon our duties. I think that it is very important that even as we push for improvement of terms and conditions of work, which we deserve, I think it's also important that we implore ourselves to improve the status of this country in terms of service delivery, because this is our profession. I don't think that politicians are going to come and practice medicine for us. We are the ones who are going to practice medicine for us, and we must create that environment that is good for us to practice that medicine, as we also give the best to the people who have bestowed trust on us, and those are the Kenyans, those are the patients. So as we push the system to make the system better, we must also push ourselves to give better.
Thank you. Thank you so much, Dr. I think you've sufficiently tackled the questions. And let me take this conversation further now to bring in Honorable Sabina Chege. Well, a lot of questions from Kenyans asking about the Linda Mama program, and just walk us through so far how the program is going to change the face of maternal care in the country. Of course, if you look at statistics from the UNICEF report of 2014, it shows that out of the maternal cases in the country, 91% of mothers who are coming from a privileged background, that is a rich background where they can afford healthcare, they're attended to very well. 31% of mothers who go to deliver in public facilities who cannot afford to pay are rather facing the risk of either abuse or even neglect during childbirth.
Thank you very much. Allow me to actually talk about Linda Mama and UHC. The government started with Linda Mama, where we said every woman who gets pregnant should have access to free and quality health care. That means when every mother in this nation conceives, they should go to the nearest health facility. They register with Linda Mama, which is under NHIF, which is a free service. So they are able to access to health care before they get their child or before they give birth, and even after. The challenge with Linda Mama has been on the way it has been managed by the counties and the facilities.
Yeah.
We, as a health committee, tried to do a proposal to the budget committee and in the House to amend the PFM Act. Because what happens with the facilities, once they render services to the mothers, then they are supposed to be reimbursed by NHIF. But what has been happening is that once they do requests for NHIF, NHIF gives back the money not to the facility but to the county account. So that does not guarantee if facility A had taken care of 100 mothers that they will equally get reimbursed for the services they gave. So you'll find that maybe the mothers, yes, will go to a facility, they will not find gloves, they will not even find, sanitary towels that are required for the mothers who deliver, and those are special sanitary towels. And so from where I sit, I think we really need to relook at it. Initially, we asked, why should Linda Mama take care of a mother? Once she delivers, then you leave it at that point. We also had a challenge where a mother gets a child who has a challenge and might need to be readmitted or referred. For example, in Nairobi, if a mother gets a baby at Mama Lucy facility, and then that baby needs to be referred to the Kenyatta National Hospital. There were challenges where when the baby was referred to Kenyatta National Hospital, and the Linda Mama had covered this mother at Mama Lucy, then they were left on their own. And so these are some of the things that we have been pushing as a committee on NHIF reforms, because we need to make sure that whether I deliver at Mama Lucy and my baby has a challenge and I need to be referred to Kenyatta, when I go to Kenyatta, Linda Mama should take care of that baby and should take care of the baby until the baby is 1 year. It is currently maybe at up to 9 months because of immunization, but we are pushing it to be 1 year.
All right.
But also urge the counties, once the money that is reimbursed from NHIF, please don't go build roads. Take the money back to the facility so that the facilities will be adequately equipped. And that is where the gap is.
All right.
But the beauty of it all is that we are enrolling UHC in each and every, within the 47 counties. So what is this animal called UHC? Because a lot of Kenyans don't even understand it. We envisage a situation where any Kenyan can visit a level 1, that is level 2 or level 3 facility and get free access to care. And this is quality care. This is care that is affordable and also timely. So you don't get into a facility and the gates are locked. And from level 4, 5, and 6, then you need to have an NHIF card if you need specialized care. And I think this is where the gaps are. If we make sure that UHC works in this country, even with or without COVID, this would have worked for us. But the problem is that we have not gotten it right with UHC. We have to sit down as policymakers, see how the UHC will work, so that we can be able to help Kenyans. Otherwise, it's going to be a mirage. It's going just to be a word about UHC. But the dream of the people who actually came up with the UHC was to make sure that our people can get access to healthcare, and that is good healthcare, which is affordable and quality and also timely.
All right. And Mheshimiwa, still staying with you, I just want to understand from you, in terms of funding for Linda Mama, do you have sufficient funds? Looking at the latest budget, the health docket received just about 90 billion shillings. And when you also look at the big picture, from the estimates that are supposed to be going towards funding health, we should be looking at about 15% of the national budget going towards healthcare. And for Kenya, it's just at about 6%. As legislators, what are you doing towards enhancing this?
You know, when we say about 15%, it's interesting because when we interact with the counties, they say they give 30% of their budgets to healthcare.
Yeah.
What was left to the national government was the policy and very little, you know, on what is happening on the ground. Mm-hmm. But we are not able to tell. I can tell you there's a lot of money in healthcare. We will never get enough. And I heard Angela saying we need enough health workers. We will never reach that level of enough. But are we using prudently what we are given? That's a big question. If you look at UHC and make sure that from our community health, who are volunteers, now we want them to be health workers, are taken care of. So we start with prevention. If we focus on that level, the lowest level, we don't need to use the billions we have used for MES.
Yeah.
We don't need the billions that we are buying big machines. I personally visited Cuba. I was amazed that they have a community doctor at that lowest level, that a doctor visits a minimum of 10 homes in a day, whether the families they are sick or not sick.
Yes.
The issue of maternal, you know, death, or even having the children between the age of 0 to 5 dying in Cuba is unheard of. The issue of the training is different from how we do our training in Kenya. And I think we need to really focus and ask ourselves the hard questions. I'm happy that my friend Olunga now is in management of healthcare, and especially in, you know, in Nairobi.
Yeah.
I want first to congratulate him because I didn't leave him at that position, but now it's the high time that we sit, and that's why I said we need to have a candid conversation.
All right.
Because it starts with me as a legislator. What can I offer? What kind of advice can I offer to the ministry? Then what can the ministry also offer to the public?
All right, thank you.
What can the counties do? Because health is devolved. So we really need to work together so that we achieve UHC. And once we get UHC, whether any pandemic hits us, we're going to be ready. But as per now, for sure, we were not ready. We were caught flat-footed. And that's why you've seen many things happening, people fearing even to attend to healthcare, even to go to hospitals. Maybe that's why this lady was living 3 minutes away from the facility, from the hospital.
Yeah.
But remember, before we were told Pumwani there was COVID, maybe she was afraid to go. I don't want to talk on her behalf.
Correct.
So we have to ask ourselves the hard question and give candid answers, but we must work together.
Thank you so much, Honorable Shege. Let me bring in Madam Angela. Well, when you hear Dr. Lunga talking of Pumwani being the largest referral hospital when it comes to pregnant women, and from where you sit, what can we do differently, especially in setting up other similar facilities across the country, because at the end of the day, Kenyans want to get quality health care and they want their taxes to work for them.
I think for me, first, even before I answer that question, which I think is a very fundamental question, I want to take a step back to the issues that Dr. Oluga talked about and also Mheshimiwa Shege. I'm glad that we're talking about, we responded and we are able to provide a way for our mothers to go to health facilities when they need it, and the aspect of board came in, and the aspect of many other things that were done. But all of us know that when COVID struck this country, I call it too little, too late. It took forever for reproductive health or maternal health services to be made, for guidelines to be issued for continuity of care. And as such, many mothers went to delivered at home because of the curfew issues, the lockdown issues. What does that tell us? That tells us that even after living in a continent which had experienced so many pandemics, like West Africa, Congo, and the like, and there were so many lessons that we could have drawn and put in place measures to ensure that continuity of essential services actually is put in place such that we are not caught, as Mheshimiwa puts it, flat-footed. We never did that. And it took like almost 2 months for those guidelines to be put in place. And that was a miss. We had mothers delivering, and I'm talking about a survey we did in 6 counties, and we had mothers delivering at home, we had mothers dying at home, and the media was awash with news about mothers who had delivered at home or died at home. So let's realize that we missed a point and we need to learn from that. Coming to the board, the aspect of board, it's a little effort that was put. But I want to ask all of them, how many people living in Kibera, for example, in Korogosho can access board? How many of them know about board even? And more to that, issues about security in the informal settlements at night have been an issue. I keep on saying when I speak that maternal health is not just a Minister of Health issue. It is a multi-sectoral issue that will inquire many people coming together, many stakeholders, including you and me, citizens also, to come on the table to say, what are the issues? But if we put a small effort and assume we are equitable, and now that brings me to the aspect of UHC. The principle of UHC was about leaving no one behind and ensuring that the farthest are reached first. The aspect of the principle of quality was number 1. 2, there was an element of equity and dignity. Of course, that is a far-fetched dream. We're still not there. So what I see fueled all across is the financial aspect of it, which we are still yet to see. I think that the pilot counties, and I'm glad that the governors from those counties came out and said UHC failed, because we did not consult widely, we did not learn, and more to that, we did not invest in what was really necessary. 1, we did not invest on health literacy. We did not educate that mother who lived in 3 minutes away from Pumwani on what are the danger signs, what does she need to expect. So health literacy is never funded for, is never budgeted for, it's not part of the conversation. Number 2, we did not think around issues around what is the role of that woman in determining what quality of care means to her. We talk about quality. It's all about the policymaker talking about quality. It's about other people talking. But the biggest stakeholder, the citizen, the 90% of the player is never on the table. We never consult the citizen. We always assume we know what they want. And I will talk to this because last year we undertook a survey to understand what quality means to women and girls. We were shocked because quality to women and girls is not what quality will mean maybe to Dr. Oluga or to Mheshimiwa Shege or other players in the sector. Quality to women and girls means respect and dignity when they go to the health facility. Jacqueline, who delivered outside Pumwani Maternity Hospital, did not receive that dignity. So quality to her was compromised. Quality of care to that woman who is delivering and pregnant means that when she gets to a health facility, she needs to find running water. She needs to be talked to she needs to be called by name. She needs to be ensure that the floor is not dirty. So at the end of the day, even as we think all these things we are thinking about reforms and the like, can we first ask ourselves, are we put in place the right to stakeholders on the table? Do we even know what they want? And more to that, the other thing that I really want to question before I go to your question is the aspect of free. Linda Mama is not free, it is taxpayer funded. So at the end of the day, we cannot keep on saying it is free, and then we make people believe that it's free, and at the end of the day, when they go to that health facility, they find nothing. It is taxpayer funded, and it is one of the most complex things that mothers told us. They do not know how to maneuver around it to ensure that they actually get to know it. There is no civic education for that mother to understand, what do I need to do? So can we ensure that we go back to the field and ask, to the drawing board and ask ourselves, what is the problem? What do we need to do? Instead of coming up with very complicated and good things, but at the end of the day, they don't speak to the needs of that woman. Can we ensure that we invest in health literacy? Can we invest in things that are going to change this woman's life, this newborn's life at the end of the day?
Thank you.
Coming to the question is,
kindly make it brief. Make it brief.
Sorry. Yeah, coming to the last question is, we need to I think we feel we need to dismantle so much that is happening. We need to understand that even as the Senate, whether it is the county governments, whether it's the NMS, whether it is the central government, when they are fighting, it is the woman and newborn who is suffering. So instead of all this happening, why can't we all come together and agree what needs to be done and listen to what mothers and their newborns want and deliver it? Thank you.
All right, thank you. And Honorable Shege, would you want to make a quick rejoinder? There are so many concerns around Linda Mama and the UHC that remain a thorny issue for Kenyans.
What I would want to say about UHC is that it didn't fail. The 4 counties were meant to be pilots. The concept behind pilot is for lesson learned.
All right.
So that as you implement, then you know how to do it. Initially, it was envisaged that UHC is going to be free, you know, from level 1 to all the way to level 6. And that's what they did with Nyeri, Isiolo, Machakos, and they gave the UHC card and ignored the aspect of NHIF. So lesson learned was that this was not affordable and they needed to do and focus much more on preventive. So as a way forward, it was agreed that they are going to have KEMSA, you know, give enough essential drugs to level 2, level 3, level 4, and all the way. So the counties can be able to draw from an account that is provided for by the national government.
All right, thank you for that clarification.
But from level 4, if you need specified or, you know, proper health care, or you are referred for the referrals, you needed to have an NHIF card. So unlike where the counties are where we piloted and we were having UHC card, so we are no longer having UHC card in any county. When you go to the dispensary, when you go to level 3, and level 4, you'll actually get treated, you'll not be charged because the government is taking care of that. But at higher level where things become complicated, then you need to have your NHIF card.
All right.
So that was the difference between what was piloted and now what is being implemented.
Okay.
But the biggest challenge you are having with healthcare, even with Linda Mama, yes, we have money. And I would say we have enough money to take care of all our mothers in this nation. But once we reimburse this money, because the facilities normally, you know, ask for money, reimbursement from NHIF, but that money does not strictly go to the facility. We are trying to see how we can have committees at that lowest level. So if a facility takes care of 100 mothers, they should be reimbursed equal amount by NHIF, and that money should go not to the county account, but to that facility, so that then we'll avoid the issues of when a mother goes, there are no sanitary towels, you know, you don't even have cotton wool, you don't have proper facilities, then you can be able to reinvest back in that facility that is taking care of the mothers. So that has been the biggest gap, and if we manage it, because we propose an amendment of PFM Act, we are trying to see with the governors how we can be able to work together. If that money goes back to a specific facility, not to the county account, because we have found some governors would wish with that money to build roads, you know, something that will make you more popular, and then ignore the health care. So that's what has been happening.
Thank you. Thank you.
So we need to make sure that the money meant for health goes to the health facilities.
All right. So I'd
then
like
we'll
to
manage to take care of those women, and actually Linda Mama is going to be free.
Thank you. Thank you, Honorable Shege. I'd like to get some reactions after this break from Dr. Lunga on the way forward, especially in terms of building other centers of excellence across the counties, across the healthcare system. We'll be back after this quick commercial break. Keep it here on KTN News.